All right, I'm excited to introduce Dr. Lauren Gerlach. She is a graduate from Western University of Health Sciences and completed her residency at the University of Michigan Health System in Psychiatry. She is an assistant professor, geriatric psychiatrist in the Department of Psychiatry at U of M. Her research is focused on understanding trends and appropriate use of psychotropic medications among older adults, including evaluating how psychotropic medications are utilized in end-of-life care. Her work aims to inform safe and rational psychotropic medication prescribing among older adults, including understanding how to best target appropriate treatment to patients that would benefit from the treatment the most. Today, she will be speaking on the diagnosis and management of neuropsychiatric symptoms in Parkinson's. Please give a warm welcome to Dr. Gerlach.
All right. There we go. Thank you very much for that introduction. I'm very happy to be here today and have the opportunity to speak to all of you. So I'm a geriatric psychiatrist, so clinically I work with patients who are generally age 60 or 65 and older who have a variety of mental health issues, whether they be depression, anxiety, as well as patients who have various forms of cognitive impairment or dementia, as well as patients with movement disorders such as Parkinson's disease. And I'm going to talk a little bit today about what we call the neuropsychiatric symptoms or the non-motor symptoms of Parkinson's disease. So I'm fortunate at University of Michigan to work with a large cohort of friends and colleagues. At Michigan, we're very fortunate to have one of the largest concentrations of geriatric psychiatrists in the United States. So for those who may need clinical services, we're certainly more than happy to help if we can. So objectives for today, we're going to talk some about identifying what are the neuropsychiatric or non-motor symptoms in Parkinson's disease, to understand what they are and how to identify them. And then we'll also spend time talking about the known treatments for these non-motor Parkinson's symptoms. So Parkinson's disease is described as a movement disorder with characteristic motor symptoms such as tremor. However, even from the earliest descriptions of Parkinson's disease, there was a recognition of the importance of what we term non-motor symptoms. So James Parkinson in 1817 published the essay on the shaking palsy, which was the first description of Parkinson's. And even at that time, described the disorder that it affects many systems other than just motor. So it can affect people's mood and spirits, their perceptions, as well as their cognition or thinking. So what are the non-motor or neuropsychiatric symptoms in Parkinson's disease? Well, these really encompass a range of different symptoms and syndromes. So it can include depression, so feelings of sadness, low mood, apathy, which is closely related but is a lack of motivation, difficulty with initiative or drive, anxiety, which can be restlessness or repetitive worries, compulsions, which can be repetitive thoughts or behaviors, psychosis. These can be symptoms like abnormalities including hallucinations, either hearing or seeing things that aren't there, or difficulty with different sensory perceptions, as well as dementia or other forms of cognitive impairment. And as you can see, the rates and incidence of these symptoms are very common in Parkinson's disease, but sometimes are difficult to detect, and sometimes patients and caregivers may have some difficulty expressing these to their clinician. And it's important that we talk about these today because these non-motor symptoms often create the most challenges for patients and caregivers, and that these symptoms have been linked to many things, including difficulty with day-to-day tasks, can cause increased caregiver burden. These can often be symptoms that trigger nursing home placement, as well as lead to things such as caregiver distress and depression. So let's talk a little bit about a patient. So this is Mr. F. He's had Parkinson's disease for about 10 years now. His motor symptoms are well controlled on carbidopa-levodopa. However, his wife reports that he's been depressed, he seemed more anxious, he's been tearful, and he's been withdrawn. He hasn't had a lot of desire to engage in typical activities that he would like to. So depression in Parkinson's disease is very common. So about 50% of Parkinson's patients have some symptoms of depression, and nearly 1 in 5 have a characterized major depressive disorder. However, even though these symptoms are common, they're often undertreated. Some studies have shown that less than 1% of patients had revealed depressive symptoms to their clinician. And it's important to address and to treat these symptoms because depression can decrease quality of life, and often that can have more of an impact than even the motor symptoms at times. So what are the symptoms of depression? So depression is often characterized by low mood, so that can be low spirits, feeling sad. It's also characterized by what we call anhedonia, and this is a lack of interest or pleasure in activities. And that can come out in several different ways. Patients might say, I just don't feel well enough. I don't have the energy. Families may notice that they're starting to neglect their personal appearance or kind of upkeep of the home. And they may withdraw from social activities that previously they enjoyed. We can see weight changes. Folks can notice that their appetite is too good or they don't have an appetite at all. They can have changes in sleep, either sleeping too much and finding it hard to get out of bed, or finding that they can't fall asleep at night. There's activity changes. People can feel restless or slow down. And often these are accompanied at times in more severe depressions by feelings of worthlessness, guilt, or burden. Folks can have difficulty concentrating, trouble making decisions. They may have fatigue or loss of energy. And in severe depression, folks can have thoughts of death or suicidal ideation. As I was reading off those lists of symptoms, you may have noticed that sometimes it can be difficult to distinguish depression from some of the features of Parkinson's disease. So certainly some of these symptoms can be seen across both depression and in Parkinson's. So sleep disturbances we know are common in Parkinson's, whether it be REM behavior disorder or insomnia. We know fatigue can be a common physical symptoms in Parkinson's, as well as slowing of the gait or motor abilities. There can be concentration or memory impairment that's part of Parkinson's and separate from depression, as well as social withdrawal, sometimes due to either dyskinesias or the involuntary movements or slowing. Folks may choose not to engage in many social activities. And then dementia, so some of the symptoms that come with that. So it can be sometimes difficult to tease apart what symptoms might be due to the underlying Parkinson's versus what might be due to depression or a major depressive disorder. And it's important to know that depression and Parkinson's is not just due to living and coping with a serious medical illness or neurodegenerative disease, but there's also fundamental changes in the brain that occurred due to the Parkinson's that can increase risk of developing depressive symptoms. So in Parkinson's disease, neurotransmitter or chemical levels in the brain are low for dopamine, serotonin, norepinephrine, and these low levels can cause depression and anxiety. And due to some of the disruptions in the circuit and networks in the brain, that can put patients at a greater propensity or risk for developing depression. Anxiety is also very common in Parkinson's disease, and about 40% of patients meet criteria for an anxiety disorder. And so that can include generalized anxiety disorder, which are generalized repetitive worries about certain topics. It may be related to health, finances, the future. Folks often can have physical symptoms with the anxiety, feeling restless, keyed up, on edge, having a nervous stomach or rapid heartbeat. We can also see other anxiety disorders like obsessive compulsive disorder, where people have repetitive thoughts or behaviors, as well as panic disorder. And some studies have shown that these anxious or anxiety symptoms may actually predate the diagnosis of Parkinson's by several years. So these can be what we sometimes call prodromal, or early symptoms that occur even before the diagnosis of Parkinson's disease is made. And these anxiety symptoms can often be found with other psychiatric disorders or psychiatric symptoms, such as depression. When we think about treating patients with Parkinson's disease who may have anxiety or depression, there are certain aspects of Parkinson's disease that we think about a little bit differently than we would, say, a general adult who came into our general psychiatry clinic. And this is because sometimes these mood and anxious symptoms can be very much tied into the motor symptoms of Parkinson's. So folks may find that as their medications are wearing off, that they may experience some of these symptoms. So as the dose of Sinemet is wearing off, patients may notice that they feel more anxious or panicky, or they may notice some fluctuation in their mood related to either these on or off periods with the medication. So we're always asking about that and trying to figure out if there's perhaps a temporal association between the medication use and some of the symptoms that people are having. We always ask about sleep and REM behaviors. We want to ask about falls because some of the medications that we prescribe may make people more at risk of having falls, and those are medications we would avoid. And we'll talk about some of these other areas, but we always ask about psychosis, so if people are experiencing hallucinations, if they're having any changes in their thinking or thoughts, and if they're having any difficulty with their memory or having any difficulty doing things for themselves that previously they were able to do without problem. And then we also ask about potential overuse of Parkinson's medication. So sometimes when people are taking too much of the prescribed medication, either unintentionally or intentionally, that can cause some of these symptoms as well, which is important for us to understand. In terms of treating depression and anxiety and Parkinson's disease, if these symptoms are primarily related to when the medications are wearing off, or during these off periods that we'll call it, our first step is usually to adjust the Parkinson's medication. So we'll talk with the patient's neurologist and find a better schedule of medications, either longer acting agents or making sure that the medications are adjusted to address those things. If it's unrelated to motor fluctuations, or if adjusting the Parkinson's medications has not resolved the symptoms that patients are having, for mild depression, we'll generally think about counseling. So there are many different types of psychotherapy. Cognitive behavioral therapy can be a very efficacious and useful form of therapy to help patients with mild to moderate depression. And I work as a geriatric psychiatrist, so I work with older adults. People often, when I mention therapy, think very much of how therapy was in the 1950s and 1960s. So they ask if they're going to have to lay on a couch and talk about their mother, and I assure them that's not the case. So cognitive behavioral therapy is very much focused on the here and now, and focused on addressing either repetitive thoughts or worries that folks have, as well as giving them a set of skills and tools to better be able to behaviorally manage mood and anxiety symptoms. And folks also often ask how long therapy would last for, or how long they would be expected to be in treatment. And whereas older forms of therapy, like psychodynamic or psychoanalytic therapy, people might be in therapy for years, with cognitive behavioral therapy, we're generally thinking anywhere from, say, a 2 to 6 month treatment time. So much shorter course of therapy. And for more moderate to severe depression, we're often thinking about using psychiatric medications like antidepressants, often in conjunction with therapy as well. And most of our research has found that that combination of medications plus therapy really tends to be better than either alone. And then later we'll talk about some treatment options for more severe depression. Okay, in terms of the medications that we use to treat depression and anxiety, here are some common classes of medications. So the SSRIs are called selective serotonin reuptake inhibitors, and these are the most common antidepressants available. This includes medications such as citalopram, sertraline, escitalopram, fluoxetine, and these medications are generally well tolerated. They do come with some side effects, so they work by increasing levels of serotonin in the brain, which is very much involved in depression and anxiety. There also tends to be a lot of serotonin receptors in our gut and stomach, so upset stomach, nausea, diarrhea, those are the most common side effects that we see with these medications, but often if we start at a low dose and once folks have been on the medications for a bit, generally they can be well tolerated. So again, I work primarily with older adults, so I'm often trying to look for medications that have the fewest drug-drug interactions, and especially with patients with Parkinson's disease, they may be on several different prescribed medications, so it's important to choose medications that don't have interactions with their other medications. So citalopram, sertraline, and escitalopram are probably the 3 most commonly prescribed medications for that very reason. There are some medications here, such as paroxetine or what's called Paxil, and while this medication can be very helpful in younger adults, in older adults we often avoid using this medication because it's highly anticholinergic. And what that means is medications that are anticholinergic can have profound side effects for older adults. So they can cause worsening confusion, they can cause dry mouth, constipation, urinary retention, they can increase the risk of falls. So there are certain types of antidepressants that we sometimes avoid using in older adults. That to say, in case anyone here is on paroxetine, it can be very safe, so you don't have to go to your doctor immediately and tell them you need to come off. However, some people do experience those side effects, and so we just have to be cautious when starting and using that medication. Another antidepressant class is called the SNRIs. So these are serotonin and norepinephrine reuptake inhibitors. So these work on two chemicals in the brain. They work on both serotonin and norepinephrine. And norepinephrine is kind of like your adrenaline, very similar to that. So it's kind of a little bit activating. And these medications can be helpful sometimes for patients who have a lot of apathy, low mood, what we call inertia, so kind of hard to get going, low motivation. Sometimes these medications can give a little bit of a boost. All of these medications in the SNRI category also have an indication for chronic pain. So if patients have depression plus chronic pain, whether it be neuropathy, whether it be chronic back pain, sometimes we'll think about kind of two birds, one stone. And these medications can be very safely used in Parkinson's disease as well. All of these medications, since they work on norepinephrine, which again is that adrenaline-like chemical, have some risk of increasing blood pressure. However, for Parkinson's patients, often the issue is the opposite, that their blood pressure is too low. So sometimes that can be, that can easily be monitored. But those are some things that we think about. Some other classes of medication, so bupropion or Wellbutrin, works a little bit differently than the other medications that I discussed. This medication works on norepinephrine and a chemical called dopamine. And this is a very activating medication. So again, if people have low energy, low mood, hard to get going, sometimes it can give a little bit of a boost. However, for patients who have a lot of anxiety, sometimes this medication can be too stimulating and can sometimes worsen anxiety. So we do have to think about the side effects and different profiles of these medications when trying to decide what makes the most sense for an individual patient. Mirtazapine or Remeron is another antidepressant, and it tends to be pretty sedating, so it's given at night before bedtime. That can be used to our advantage if patients have insomnia or difficulty sleeping. Sometimes that can be helpful. It also tends to be very weight promoting, so it increases people's appetite, which can either be a good thing or a bad thing. So if people have lost their appetite, they're losing a lot of weight, this class of medication can help stimulate that. However, if patients have trouble with overeating or perhaps have diabetes, that's something that we tend to avoid or to at least be cautious about. And then there's some older medications called tricyclic antidepressants. These are medications like nortriptyline or desipramine, and these are some of our earliest antidepressants. They, like the SNRIs that we talked about, all have an indication for chronic pain. So sometimes if patients have both neuropathy, chronic pain, and depression, we'll use these medications. They do come with a host of side effects that we have to be careful about. So these medications also have what we call those anticholinergic side effects. So sometimes they can cause confusion, dry mouth, constipation, but they can be very potent antidepressants as well. And then there's some older agents called the monoamine oxidase inhibitors, and these are medications like tranylcypromine, phenelzine, or selegiline. And these are medications that prevent the breakdown of the chemicals that are important in depression and anxiety. So they help boost the levels of serotonin, norepinephrine, dopamine. These medications come with a host of side effects as well, but again, for more severe refractory depression, they can be helpful. And then selegiline, some people in this room might be taking, or rasagiline, and so that medication also gets used for Parkinson's as well. And then whenever I prescribe an antidepressant medication, I think it's very important for physicians to counsel both patients and their caregivers about why is this medication important? Why are they taking it? It's also important for them to know how long it will take for these medications to work. Unfortunately, if anyone here has ever taken an antidepressant, you know that these medications don't work instantaneously. They take time to build up in your system and to be effective. So these medications can really take anywhere from 6 to 12 weeks to get maximal benefit. And that can be frustrating, especially if people are suffering and they want to feel better soon. But I think it's very important for people to know that, because very often in the office, people will come in and say, I took the medication for 3 days. I didn't notice any difference, so I stopped taking it. I didn't want to bother you, and now I'm seeing you 2 months later, but still having severe depression. That's a situation we want to avoid. So it's important for people to know that you really need to stick on these medications for them to work. It's also important for people to understand what the possible side effects are of the medication. As we reviewed some of the common classes, you could see that there's some medications that have a higher chance of having some side effects versus others. So it's very important for caregivers and patients to know what to look for and what to expect with the medication. It's also important for people to know how long to stay on treatment, and it's important, I think, for us to write out directions, because often there can be a lot of information that's being provided during the appointment that when people have questions later, it helps to be able to have kind of a written schedule of how to take the medication. Kind of the general tenets for geriatric psychiatry and prescribing psychiatric medications is start low, go slow, but don't stop. Generally, the starting dose of these medications are going to be about a quarter to half the usual starting dose for younger adults. And we tend to titrate or increase the dose of the medication slowly. So every 4 to 6 weeks, we may make another dose adjustment. But it's important, if people aren't having resolution of their symptoms, that we don't stop at low doses, that we keep pushing to an effective treatment dose. Even though we start slowly and start at a low dose, many older adults and patients with Parkinson's disease will need the same doses as a younger adult. It may just take a little bit longer for us to get there. And then a reminder to be patient, that these medications can take anywhere from 8 to 12 weeks to be maximally effective. In terms of the treatment duration, if someone has a first episode of depression or anxiety, generally we're going to recommend staying on treatment for about 6 to 9 months after remission of symptoms. After that time, if patients say, I already take so many medications, I really want to try to get off this one, then we'll do a slow taper and slowly go down and take off the medication. For patients who have recurrent episodes of depression or severe depression, generally we'll say 3 strikes and you're on, meaning that if people have recurrent episodes, we generally recommend lifelong treatment. And that's because continuing treatment really prevents relapse and improves quality of life and outcomes for patients. And just like patients who are taking insulin for diabetes or taking antihypertensives for blood pressure, these medications can really help keep you well. So electroconvulsive therapy, I'll mention briefly. So most people's perception of ECT or electroconvulsive therapy is based off of One Flew Over the Cuckoo's Nest, or treatment from the 1950s or 1960s. But the way that ECT is done now is very different from how it was done then. And it's actually a very safe and effective treatment for severe depression. Generally, it's indicated for patients who have failed several antidepressants or have severe symptoms where they're not taking care of themselves. They may have suicidal ideation. They may not be eating. And it can be a very safe and rapid treatment for depression. So most of our antidepressants have anywhere from a 40 to 50% response rate, meaning that when a patient tries a new antidepressant, there's about a 40 to 50% chance that that patient will have full remission of their symptoms. For ECT, the remission or response rate is about 85 to 90%, so that's better than any of our medications. Folks usually get anywhere from 8 to 12 treatments and sometimes require maintenance treatment after that, and these are done in the hospital or as an outpatient. And interestingly, patients who have Parkinson's disease and depression actually have an improvement in their motor symptoms for several weeks after the ECT treatment. Mortality rate is very low and is generally related to the risk of anesthesia. And folks often ask if there's an upper age limit in terms of who can receive this procedure. And our record at University of Michigan currently is 97 years old. So again, there are risks. It's related to anesthesia, but can be a safe and fast treatment for folks with severe depression. So let's get back to Mr. F. So he was started on an antidepressant medication, escitalopram. His family noted that he stopped crying and reported some improvement in his mood. However, his wife says that he's really sitting around for most of the day, and it's hard to get him going, and he just doesn't have a lot of motivation to do things. So closely related to depression is apathy, and this is a lack of motivation and interest in goal-directed activities. So it's not necessarily a lack of pleasure, it's just a lack of interest or motivation to do these things. And it's really emerging as a common symptom in Parkinson's patients and can occur in anywhere from 40 to 60% of patients. And it's important to know that apathy can occur with depression or it can occur without depression. So apathy alone does not have the typical sadness, crying, anxiety, helplessness, guilt that's associated with depression, but sometimes they can happen together. And apathy can often be very challenging for caregivers and can sometimes lead to resentment. So folks might think that it's intentional, that individuals are being lazy, and sometimes it can make caregiving unrewarding. And so it's important to try to remember that it's the disease, it's not the person. And apathy is biological as well, too. So as there is some degeneration in certain circuits, especially in the front areas of our brain, that can lead to apathy symptoms in patients with Parkinson's. In terms of treatment, medications can sometimes be helpful, but the studies show there's generally a time-limited or limited benefit. For some patients, we may try using a stimulant medication like methylphenidate or Ritalin, or another medication called modafinil or Provigil, and sometimes that can help boost kind of energy or motivation. However, behavioral interventions really tend to work the best. So often we say, rather than asking, do you want to, you may just provide a list of several options for people to do. So active coaching, let's go, let's get out there and do things. So trying to push people. I often say that you don't need motivation for behavior. It certainly helps, but if I waited for motivation to go to the gym, I may never get there. So sometimes we have to start doing behaviors, and we find that the motivation follows that, but it can be very challenging for both patients and caregivers. So back to Mr. F. So his depression seems improved. He's still apathetic, except his wife has started to notice some unusual behaviors. So at their condo complex, there's been a couple episodes where he's been standing at the window and has actually exposed himself and has been more disinhibited. And his wife is really frustrated because he's spending so much time with online gambling and actually broke their home computer. So these impulse control symptoms in Parkinson's disease. So these can include many behaviors. So these are new behaviors, so things that perhaps were not part of someone's typical activities or behaviors beforehand, but these can include things like pathological gambling, hypersexuality, compulsive buying, or binge eating. And these are kind of a change from someone's normal, or at least a significant increase from someone's typical behaviors. And these can occur in anywhere from 6 to 25% of patients with Parkinson's disease, and often tends to be tied with the use of dopamine agonists. So many times this is a direct side effect of the medications that people are taking to control their Parkinson's disease. We can also see some compulsive behavior. So people can get very fixated with certain hobbies. Punding is kind of this repetitive sorting, organizing, kind of arranging things in certain organizations. And often these can be due to what we call this dopamine dysregulation syndrome. So they can be due to the prescribed medications. They also can be due to people are taking more than the prescribed amount of medications for Parkinson's. And generally, our first step for treating is to decrease the dopamine replacement therapy, and that's often effective for folks. So either we try to stop or switch agents. There are some behavioral interventions that can be helpful for these compulsive behaviors, and there are some medications available too, and generally we try to target the type of medication that we're prescribing to the symptoms that folks are having. So for instance, if there's significant disinhibition, hypersexuality, we may prescribe more of a mood stabilizing agent that might help with that. If it's more on the compulsive repetitive actions, sometimes antidepressant medications can be helpful. But generally for these most most do improve with changing the dopamine replacement therapy. Again, important to know that these behaviors are not intentional. They are part of the disease or part of a consequence of the treatment of the disease, but can certainly be very distressing. So Mr. F again, so the dopamine agonist was stopped by the neurologist, and he had significant improvement in some of these disinhibited and compulsive behaviors. However, he's starting to insist that his wife is having affairs. He sees cars kind of pulling down the street, and he knows that these are suitors coming to visit his wife, who is 85 years old. Notes that the flashing porch lights are a secret code, and evidence in his yearbook shows evidence to suggest that this is the case. So psychosis in Parkinson's disease is very common. So up to 30% of patients report psychotic symptoms. And these can include symptoms like hallucinations, illusions. So for instance, seeing shadows on the walls and thinking that it's someone there, or delusions, which are kind of fixed false beliefs or beliefs that are not typically held by them. About 20 to 30% can have hallucinations or delusions, and that can certainly be common in certain types of illness, such as Lewy body dementia. But up to 50% of patients may have milder symptoms, such as a presence, so they see something move out of their corner of their eye, but it isn't a fully formed hallucination. And hallucinations can take many forms. So they can either be seeing fully formed hallucinations, so for instance, seeing animals kind of roaming on the yard. A lot of people will report seeing small children or animals. They can have difficulty identifying people. They may believe that their loved one or other people are imposters, something we call Capgras syndrome. Or they may have different kind of shapes or illusions around shapes as well. It's important to ask patients about these and to ask kind of your loved one if they're experiencing these, because patients may be distressed by them and embarrassed to report them. So it's important that us as providers and caregivers are often inquiring or asking if these symptoms are going on. Again, these can come in many different forms, and patients may or may not have insight in that these symptoms are real or not real. And when we think about treating, that becomes very important. So for instance, I can think of patients who perhaps see the beloved family dog, and that's very reassuring to them. They know that it isn't real, but it's very comforting. Other people may have much more distressing hallucinations, people breaking into the house, people trying to harm them, that do require treatment and are very distressing for them and their caregivers. When we think about treatment, we often want to think about non-medication treatment options first. And the first thing I always think about are there any underlying sensory impairments that we need to correct for? So vision and hearing loss are the two most common causes of hallucinations, even in people who don't have Parkinson's disease. So if you imagine if you have poor vision, you can be a lot more susceptible to perhaps having some disturbances in your vision and perhaps thinking that shadow on the wall is an animal or person. Also with hearing loss, folks who have uncorrected hearing loss are at higher risk of having auditory hallucinations. So very important to try to make sure we have the right glasses, to make sure that people are wearing their hearing aids. It's also important to evaluate and treat any underlying medical issues that might be causing these. So there's a syndrome called delirium, which is kind of an acute change in concentration where people may become confused. They may have some of these psychotic symptoms. They may experience hallucinations. They may have unusual thoughts that people are trying to harm them or do bad things to them. And that can often be caused by an infection, whether it's a urinary tract infection or a pneumonia, and those things are easily treated. Also dehydration, constipation, those are medical issues that can sometimes lead to these symptoms that we want to make sure that we rule out before starting another treatment option like an antipsychotic medication. We also want to make sure that we review the list of medications that they're taking, because there are many medications that can sometimes cause these symptoms on their own. So again, we've mentioned several times anticholinergic medications. These can be medications like over-the-counter medications like Benadryl or Tylenol PM, or prescribed medications, antihistamines, that can have some of these side effects, especially for older adults. Other medications like sedative medications like benzodiazepines can sometimes put people at risk for having these side effects, as well as opiate medications. It's also important to make sure that the environment matches the level of ability for patients. And so if people are having sensory disturbances, trying to declutter the environment can be helpful. It's also important to educate both the caregiver and patient about these hallucinations, that they can be a normal part of the disease and that they're not harmful. And then it's also important to make sure that we understand if people have insight into these hallucinations or unusual or symptoms as well. Often a situation we'll get into is that the hallucination may not be particularly distressing for the patient, but it's very distressing for the family. And in that case, some education with both the family and the patient can be helpful. Knowing the underlying cause will really direct treatment. So a urinary tract infection, pain, issues with caregivers, and psychosis all are going to have very different treatment algorithms, and there's very different things that we're going to do to treat that. What we want to avoid is routinely using a medication like an antipsychotic if we don't know what the underlying cause is. So it's very important to make sure that we know what's causing these symptoms. If it is psychosis and it is distressing for the patient, we do think about different classes of medication. The most common medications are antipsychotic medications. These are medications like Clozapine, Clozapine. We'll talk some about pimavanserin and some other antipsychotic medications. And then often cholinesterase inhibitors, which are medications that are used for dementia, can sometimes help with some of these psychotic symptoms in Parkinson's as well. So antipsychotic medications, again, these are medications like Haldol, haloperidol, Zyprexa, olanzapine, quetiapine, or Seroquel. These medications can be very effective in treating psychotic symptoms, whether they be delusions, whether they be hallucinations. However, these medications do have risk. All of these medications really work by blocking dopamine, which is really part and parcel of Parkinson's disease. So the consequence of that is that really the majority of these medications can unfortunately have a big effect on the motor symptoms of Parkinson's disease. So they can often make the slowed movements, the tremor, the gait worse. And so often we have this kind of balance between trying to treat the distressing hallucinations or psychotic symptoms with trying to avoid worsening the motor symptoms of Parkinson's disease. So outside of the motor symptoms, there's also some other side effects that these medications carry. Many of them are sedating. They can lead to falls, cause changes in blood pressure. Most of them can cause changes to the heart rhythm, cause an abnormal or prolonged heart rhythm. They can have metabolic effects as well, which really mean weight gain, increased propensity for diabetes. And each of them have what's called a black box warning that we'll talk about, and that's the highest level of warning or risk from the U.S. Food and Drug Administration, that when these medications are used in patients who have dementia, they have an increased risk of mortality. We'll talk about that. However, the motor symptoms that we can get with these medications are not equal, and there are some medications that are much less likely to do it than others, and we'll talk about which medications they are. So I know these sound like a lot of scary side effects, but I will say quality of life is also very important. And so there are some patients who will have very distressing symptoms that it's important that we treat with these medications. But it's important for people to be aware that they do have risks. So the black box warning, again, is specifically for use of this class of medications in patients who have dementia or Parkinson's disease dementia, and kind of an analysis of many studies, some of them which are randomized controlled trials, which are kind of our strongest level of evidence in medicine, found that patients who take these medications, who have dementia, have an increased risk of death, anywhere from 1.6 to 1.7 times as compared to patients not taking these medications. So when we do have to use these medications, we often want to use the medications that are going to have the least effect or least side effects on the motor symptoms of Parkinson's. So Clozapine is an antipsychotic that has very little affinity for the dopamine receptor, so it causes very little motor side effects for patients. It can be very helpful in Parkinson's disease psychosis and for treating some of these symptoms. However, it does come with some significant side effects and requires blood monitoring because it can lower patients' white blood cell count. So it's a medication that can be very helpful but does require some blood monitoring and some active surveillance while patients are on this medication. Another medication, quetiapine or Seroquel, again, like clozapine, has very little activity on the dopamine receptor, so tends to cause, usually at lower doses, very minimal motor side effects. So this can often be helpful for patients. It's very sedating, so again, that can sometimes be helpful if people are having difficulty sleeping. It can also be helpful for anxiety and depression as well. Other medications like olanzapine or risperidone, they work more strongly on the dopamine receptor. So while they're very good antipsychotics, they sometimes tend to have a little bit more chance of causing some of the worsening motor symptoms in Parkinson's. And then medications like ziprasidone or aripiprazole are sometimes used. However, there's just a little less evidence specifically in looking at these medications in Parkinson's disease. A newer medication, pimavanserin or Nuplazid, is an antipsychotic medication that's the first antipsychotic that has no dopamine activity. So what that means is that it has limited to no chance of causing the motor symptoms of Parkinson's disease, and it was specifically approved by the FDA for use in Parkinson's disease psychosis, so it has a pretty novel mechanism of action. However, it does have side effects that are similar to the other antipsychotics. It can still cause that prolongation of the heart rhythm, and it still has the same black box warning for increased mortality when using it in patients with dementia. Cost initially made it somewhat prohibitive, although there's been a lot better prescription assistance programs. Insurance has certainly been able to cover it for many patients. And so another newer option as well. The doses of antipsychotic medications that we use in patients with Parkinson's disease or Lewy body dementia, again, is going to be very low to that of typical adults or older adults. Generally, we're using anywhere from half to a quarter of the typical starting dose and going at a little bit lower range. Again, risperidone or Risperdal is an older antipsychotic that works very strongly on dopamine. So while it's a very potent antipsychotic, it tends to have a lot of those motor side effects. Quetiapine or Seroquel, we mentioned, has very little activity on dopamine, so tends to be better in terms of not causing worsening motor side effects. It's sedating, so again, can help with sleep. It also increases people's appetite, which can be either a good or a bad thing. Olanzapine's side effects tend to be somewhere in the middle. Aripiprazole or Abilify tends to be a little less sedating and also tends to cause less weight gain than some of these other medications, so sometimes is preferred for that. And then again, Clozapine is probably the most effective antipsychotic that we have, has very little activity on dopamine, so less likely to cause the motor side effects, but does require some active blood monitoring, and there are some side effects that we have to be careful about. So back to Mr. F. So this is now several years later. His wife is finding that he's been a little bit more forgetful. He's not engaging as many activities as he was previously. She notices that he keeps asking the same question over and over again, and there's been one or two instances where he's wandered from the home. So cognitive impairment or memory difficulty in Parkinson's disease is very common, and sometimes these symptoms might even predate the diagnosis of Parkinson's disease or Lewy body dementia. And this can, so cognition and thinking really incorporates a whole range of abilities. So that can be slowed thinking, decreased attention, potentially getting lost in familiar places, difficulty with multitasking, short-term memory difficulty, and word-finding difficulty. And anywhere, this is a large range, but anywhere from about 10 to 40% of patients may have some cognitive symptoms at the time of diagnosis of Parkinson's disease, and the lifetime prevalence of dementia, say over 20 years, can be upwards of 80%. Again, the cognitive decline in Parkinson's disease and Lewy body dementia is again due to changes in the neurocircuitry and degradation of certain pathways that are important for thinking and memory. For Parkinson's disease versus other types of Parkinson's disease dementia and Lewy body dementia versus other types of dementia like vascular dementia or what's more commonly Alzheimer's disease, there tends to be earlier disruptions in what we call visual spatial skills. So these are kind of the skills that are involved in constructing things, also executive dysfunction, so that's involved in planning, sequencing, organizing. These symptoms tend to be a little bit earlier, and memory difficulties develop later. Is a term of semantics for Parkinson's dementia. Typically, folks have the motor symptoms of Parkinson's first and then develop cognitive or memory issues later, whereas Lewy body, these tend to be more together. So the cognitive symptoms tend to occur within a year of the motor symptoms, so they happen earlier. With Lewy body dementia in particular, there can be very vivid visual hallucinations. These can be complex, and folks can often have a lot of fluctuations in terms of their symptoms. So sometimes it can almost seem like delirium or kind of an acute confusion. One day can have a very good day where memory is very intact. The next day they may be very confused. And REM behavior disorder as a sleep disorder often predates the diagnosis of Lewy body dementia, sometimes even by decades. So in an evaluation for cognitive impairment in Parkinson's disease, it's important, again, to correct for sensory impairments. So if people are not seeing or not hearing, it can be very hard for them to retain information. And so use of hearing aids and glasses can sometimes help that considerably. Again, it's important to rule out medical issues like pain, infection, dehydration. Again, it's important to review the list of prescribed medications to see if there's any reversible causes for memory impairment. And again, those tend to be medications like anticholinergic medications, sedatives like benzodiazepines, opiates. And sometimes these medications are very necessary for the patient and they need to stay on them. However, we're trying to really minimize things that might be fueling the fire or might be worsening thinking or concentration. Sometimes we'll check some general labs. There's some vitamin levels and different hormone levels like thyroid hormone levels that can sometimes impact thinking and concentration as well. And then we always want to rule out depression and assess for depression as well. So there's a term called pseudo-dementia or reversible dementia of depression. So when older adults have depression, they can often have with it difficulty with their memory and thinking that can often improve once the depression is treated. So we always want to make sure that there's not an underlying depression that's confounding or causing some of the memory symptoms. In terms of treating cognitive symptoms, so generally we want to try to get rid of things that could be worsening memory, but then there are two different medication classes that can be helpful. So the cholinesterase inhibitors, these are medications like Aricept or donepezil or rivastigmine or Exelon. These medications all work by increasing the amount of a chemical called acetylcholine in the brain. And this chemical or neurotransmitter is integrally involved in memory, concentration, and kind of consolidation of memory. And so what these medications do is they help more acetylcholine stay around in the brain. And these medications, unfortunately, they don't reverse or stop the memory decline or dementia. However, they can slow the progression of the illness, generally by somewhere between a 6 to 10 month period of time. For patients with Lewy body dementia, they tend to be very responsive to these medications, sometimes with alertness, but also with some of these other non-motor neuropsychiatric symptoms. So for instance, with the hallucinations, sometimes patients can respond very well to these types of medications and can actually improve some of the non-motor symptoms as well. Memantine or Namenda is another medication that's commonly used in dementia, and this tends to be for more moderate or severe dementia as well, and something else that can be used. So when we think about dementia and cognitive impairment, it's also important for us to consider and monitor safety. So kind of routine things that we do in our clinic and in the neurology clinic is to make sure that the home is safe, to make sure that caregivers have the support that they need. Are there any adaptive equipment or other resources in the home that would be helpful, whether that's care aides, visiting nurses? Often because of some of the cognitive and, as we were saying, some of the planning, sequencing abilities in the brain change, often we have to think about driving evaluations. And certainly my goal as a clinician is to preserve patient autonomy as much as I can, and I want people to be independent, but we also need to make sure that people are safe. And there's several different avenues for driving evaluation through our occupational therapy program. They have a drivability program at the University of Michigan, certainly Secretary of State as well, but that's something to also monitor. And then also making sure that the environment matches the level of ability for the patient. Sometimes environments can be either over or under stimulating, and so you want to make sure that the environment at home really matches the abilities of the patient. It's important to think about advanced care planning, to think about who is your power of attorney, to make sure that goals and wishes are voiced by the patient so that they have as much input into the process as possible. And then caregiver education, so making sure that we're trying to improve communication between the patient and caregiver, as well as supporting caregivers. We often say that caregiving is one of the toughest jobs out there, and that people are drafted rather than recruited into caregiving, so it's important to assess for caregiver burden and distress as well. So just in summary, neuropsychiatric or non-motor symptoms are very common in Parkinson's disease and can significantly impact quality of life. There can be a lot of overlap between some of these symptoms, like depression, with Parkinson's disease symptoms, and they can overlap. Parkinson's disease has a wide range of psychiatric and cognitive symptoms, ranging from depression, anxiety, apathy, psychosis, to cognitive or memory loss and dementia. And the treatments are available, both medication treatments, both psychotherapy treatments, as well as kind of comprehensive evaluations to try to limit other things that might be contributing to these symptoms. So I want to thank you all for your time, and I certainly have some time for any questions that you have. Thank you. Thank you. Sure.
I have a question about, I'm way over here.
Thank you. I'm blinded by the light over here. I just want to make sure I can see you. Very good.
I know in the past that, like, if you're on insurance and you need to talk to a counselor, they'll say, oh, death of a parent, you can have 4 hours in the next 4 weeks. I have a question. That's one question. My other question is, if you recommend a dosage of one of the drugs that you were talking about, does the insurance company come back and say, no, you can't start with that one, you have to start on a different one because it costs $100 a week less? Do you run into those kinds of issues, and how do you deal with it?
Sure. So those are both great questions, and certainly address some of my day-to-day frustrations, as I'm sure yours as well. So the first question was about basically access to psychotherapy and insurance coverage for therapy. And while we know therapy is a very effective option for patients, sometimes the amount of coverage that patients are offered is subpar and far less than ideal. Certainly, so I primarily work with a Medicare population, so fortunately we do have pretty good coverage, and all of our psychotherapists take Medicare at the University of Michigan. However, I know in the community that's not the case, and so we're often trying to keep a list of Medicare providers to be able to refer patients to, so they're accruing the lowest out-of-pocket cost. What I will say is that the type of psychotherapy that we're generally recommending is relatively shorter term treatment, so hopefully within the course of a couple months someone should be able to finish a course of treatment. However, access, kind of coverage for psychotherapy services is a huge issue, and needs to be a focus as well, because often I think, and I'll try not to editorialize too much, we may prescribe medications because we don't have effective or available therapy options, so it's very important for patients and caregivers to have access to that. And then the second question was about insurance coverage of medications. Most of the medications that I'm prescribing are generic medications that are going to be covered. I try to use the medications that are going to be the most effective for patients, but also try to be cost conscious. And if there's not any clear benefit or advantage to using a more expensive medication, I'm going to use the medication with the best level of evidence that also is going to be affordable for patients and covered by insurance. But there are times that we're filling out prior authorizations. You know, for instance, newer medication like pimavanserin or Nuplazid, occasionally there's some more paperwork that needs to be done to get that covered for patients. But certainly we're more than happy to work on what we need to help get things covered. But I think those are two very big issues and good questions. Anything else? Yes.
So my father had Parkinson's and had Lewy body syndrome, and now my wife has Parkinson's, and she's a little concerned about the cognitive effects of Parkinson's. And I noticed perusing the book here in the beginning of the book where the medical stuff is, that Lewy body can be detected outside of the brain. And I'm wondering if there's a pretty easy detection mechanism for that, and if so, is there any advantage to early detection of Lewy body?
So in terms of kind of imaging or some newer kind of imaging studies like DAT scans and some of the things that they're doing, a lot of those are not fully ready for prime time, and it still remains largely a clinical syndrome and clinical diagnosis, which is frustrating. We would love if we could just easily do a blood test or a scan and be able to tell you. So generally, these are symptoms that we're getting from history as well as the physical exam. Certainly, my heart goes out for your situation. To be in a situation where two loved ones are struggling with similar diseases is challenging. One kind of other thing that I'll mention in terms of the cognitive impairment, there are some things that we can do to try to prevent cognitive impairment. And so the best evidence that we have is really what's good for your heart is good for your brain. So having good cardiovascular health, so trying to exercise, not smoking, trying to eat a good diet. These things have all been shown to help preserve cognition longer. Also making sure that you're avoiding medications that can further impact cognition, like some of the anticholinergic medications we talked about, benzodiazepines. And then we also know that education and mental stimulation is protective as well.
So the fact that Lewy body can be detected, for instance, or developed in the esophageal region, there's no test that can be done because relative to that?
So right now, I'm not aware of one. However, some of our neurologists and folks on the research side in cognitive and movement disorders may be able to answer that better, but not kind of a routine test that I order for in our clinic. Great.
You mentioned, but only once or twice, constipation as one of the symptoms. Frequent, ongoing, chronic. What would you suggest as a program?
For
Medication.
Constipation? Sure. So certainly, so constipation can be one of those early symptoms that even predate the diagnosis of Parkinson's disease and is also very common in older adults in general. Generally, folks are first going to recommend kind of a non-medication kind of option, so trying kind of fiber kind of agents, so things like Metamucil, getting plenty of fluids, prunes, make sure that you're getting some physical activity, and then talking with your primary care doctor about different either stool softeners or sometimes laxative agents that are needed. But most people are first going to recommend good hydration, good diet, kind of fiber-rich diet to start with.
If a medication is going to cause hallucinations,
Yes.
will it happen after the long term or will it happen immediately?
That's a great question. Sometimes it takes some time for those symptoms to develop. So for instance, the dopamine agonist or medications like carbidopa, levodopa, sometimes initially when patients are started on the medication, we don't see those side effects, and we may never see the side effects. But if we do, it tends to be after they've been on the medication for a period of time, or sometimes with dose escalation as they go up to higher doses of the medication. But that's a great question. Any other questions? Oh, I think I see a couple up front here. Sure. So the question is, have I seen much success with Nuplazid? So I would say that, and I've treated many patients with it, I'd say that so far it's been on par with other antipsychotics that I've used. So I haven't seen a clear, and some folks may not be happy about that answer, but I have not seen a clear efficacy difference between other antipsychotics for treating hallucinations and delusions. However, the times I will want to go to that sooner will be if people are having a lot worsening of the motor symptoms with some of the typical agents that I prescribe, like quetiapine or Seroquel or Clozapine, that really is a true advantage that you have limited exactly with the motor symptoms. But in terms of efficacy in treating hallucinations, delusions, my clinical experience is that it's been on par with other antipsychotics. Yep. Sure.
So my question pertains to treating depression for Parkinson's.
Sure.
Specifically, have you seen any studies that show the efficacy of, say, transcranial magnetic stimulation, or TMS, as an alternative and a safer way to treat depression for Parkinson's?
Sure, that's a great question. So just for those who may not be familiar with transmagnetic cranial stimulation, or TMS, it's similar to ECT in that you're directly stimulating the brain, but it's done with a magnetic impulse or coil rather than an electrical. So patients don't have to undergo anesthesia. It's an outpatient procedure. Generally, people get treatments for about a 30-minute period of time, maybe 4 or 5 times a week over a course of treatment. Generally, and I'm not specifically aware of studies that have been done specifically with transmagnetic cranial stimulation with Parkinson's disease, but I am very familiar of it in older adults. And so a couple things to think about. One is that TMS tends to be particularly helpful for patients with mild to moderate depression. So patients who have more severe depression, the response rates tend to be a little bit lower. But for folks with mild to moderate depression, it tends to work best for folks who can't tolerate psychiatric medications for a variety of reasons. So whether it be side effects, whether it's the upset stomach, whether it's other side effects that they may develop, it tends to be good for people who maybe haven't failed medications because they weren't effective but couldn't tolerate them because of side effects. So that can be another treatment option to consider. The other thing I'll mention, though, for older adults, so the way that it works is there's a magnetic coil that's in the front part of the brain here. However, for older adults, as we get older, our brain kind of moves away a little bit from our skull. There's a little bit of atrophy just naturally in all of us. So some studies have shown that TMS isn't quite as effective in older adults as it is younger adults because of that distance between the cortex and the skull. And so it tends not to be a first-line treatment for older adults because of that reason. Yeah?
Got one over here.
Sure, of course.
I have a question, but first I have a remark to make. I've been on Nuplazid since about January, and I just feel really a lot better than I had felt from other drugs. But I also want to know, is it true that men tend to get Parkinson's more than women do? And if that is true, why is it true?
Sure. And so the first part I couldn't hear. You had mentioned being on something and feeling much better. I couldn't hear which one it was.
Nuplazid.
Thank you. Okay, great. So I'm glad to hear that you've had a good response with the medication and having some improvement in the symptoms. It is true that men tend to have a higher incidence and prevalence of Parkinson's disease than women. The underlying genetic or hormonal basis to that I am not aware of. So I'm sure there are many scientists who are spending their careers discovering that, but the general rates do tend to be higher in men. But I am happy to hear that that's provided some relief. Sure. I think we have one in the front here.
I think we have time for one more.
Okay, great.
Just to piggyback on what the question she just asked, I just wonder if the incidence in your experience of Parkinson's has increased over the years.
It's a good question. In terms of epidemiologic studies, in terms of whether there's more new cases of Parkinson's, I don't have that information, so I don't want to mislead whether it's stayed relatively stable or if there's been an increased risk. Certainly, I think as we live longer, we have a greater chance to have some of these diseases by virtue of living longer, so there may be some bias there. So as we age, there's a greater chance of developing some of these diseases. And then also kind of detection and early treatment, I think, is better, so there's better recognition of the disease and early detection. Great question.
All right. Thank you very much, Doctor. That was some great information.
Thank you. All right. Thank you. Thank you all for having me.